Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hey everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about a patient I recently had who was a bodybuilder slash powerlifter. Right now he's kind of in his off season, so he's been doing a lot more powerlifting than bodybuilding. And he came in with some shoulder pain that he's been dealing with. Now, one of the things that I think is really important is to take a good, thorough look at the lifts that these athletes perform, especially in volume. Now, the technique of the lifts are all extremely important, obviously, and it's something that I think as physical therapists we should all be really well versed in. You don't have to be an extreme expert in terms of the performance of it, but I think we should be extreme experts in the safety and performance of them. Obviously, I think there are better suited strength and conditioning professionals who can really get, those last pounds out of your lift and things like that, unless you specialize in that as a physical therapist. Now, what I'm proposing really is that, as a basic knowledge, I think as physical therapists, we should know all of those lifts in terms of their safety and their adequate performance. Again, if you're going for top tier performance or competitive performance, by and large, you're probably better off going to a strength and conditioning professional or, a professional powerlifting coach. Of course, that's not a strong, fast rule, but in general, I think as a basic level, we as physical therapists should be able to look at these lifts and be able to make sure that they're safe. We have a lot of potential to really influence things in that realm. But back to the case at hand, this gentleman came in and, I talked to him at length about his program and what he's been going through. And the guy has had a lot of years under his belt, so he's kind of doing his own programming, things like that. Excuse me. So we looked at it and we looked at the volume of things that he's been doing. He came in with unilateral shoulder pain. It was only in his left side, nothing below the elbow, nothing in the neck itself, but he did have some periscapular pain, and it was actually in the distribution of the rhomboids. And that's where he was kind of developing a big trigger point, a lot of knots, as he reported. Now, in a lot of his lifts, he liked to do a lot of back squats, a lot of deadlifts, a lot of shoulder press, and he preferred the variation behind the neck, actually. And he preferred lat pull downs behind the neck as well. Now, taking into consideration all of those, they all put the shoulder into a flexed abduct position with external rotation, kind of that anterior dislocation apprehension position almost. And going through those, it makes some sense that could be a anterior structure stressor during all these lifts, but it really wouldn't make much sense for an impingement necessarily, because he's kind of clearing that space by externally rotating, especially if he's going behind. He's really externally rotating that shoulder and trying to clear essentially clearing that space, as opposed to internally rotating a la any of the special tests. So as we're going through there, all of his strength is extremely strong. I couldn't even move this guy with my body weight. He's real strong in the shoulders. I didn't see any need for any kind of strength or any isolated rotator cuff performance there. So we take him through a repeated movement exam. Day one, I looked through his shoulder, and I found that internal rotation, so kind of behind the back, seemed to give him some relief. It improved his elevation in flexion and abduction, and it reduced some of the pain actually with internal rotation resistive testing. So send him home with that, take him for that for a bit, and a couple days later he comes back in, says, I'm feeling better, not fixed, but I'm better. So we take another look through the shoulder there and see if we've got the appropriate variation. We actually end up giving it the overpressure using a towel as opposed to just the active range of motion there. We continue on through that, take him through another few days there because he did get some benefit in clinic with that. When he returned, he's still better, but everything's still about the same in terms of the location of his problem, the patterns of provocation, and things like that. So everything had just decreased intensity, but it hadn't really changed the pattern of that problem. Because of that, I did a quick screen of his neck. It was something that I looked at very briefly in the initial exam. I had him do some retraction extension, see if that affected anything, and it really didn't send him one way or the other. He had seen a chiropractor previously who had manipulated the cervical spine. He reported no difference, not even worse from that. So, I hadn't been thinking cervical, but at this follow-up, about the third time, I put him into supine on the table, and retraction, traction, extension over the end of the table. We go through a couple rounds of those, and we abolish his pain with elevation. So I go, okay, well, we're getting somewhere here. This is changing the pattern rather than just decreasing the intensity and things like that. All of a sudden, something that was provocative is no longer even painful. So that was the last time I had seen him right now, and we're kind of waiting to find out the results here. I'm actually going to give him a call tomorrow in the clinic, but as we're going through with that, I'm thinking more along the lines of this guy's got maybe a little bit of both, a little bit of cervical and glenohumeral derangement syndrome going on. He responded a bit to both, and we'll kind of see what comes of it. So I wanted to update you guys on that. He's a big powerlifter guy, and not everybody needs to be strengthened, that's for sure. So take that for what it's worth, guys. As always, move your patients early, move them often, and move them to end range, because that's where the magic happens. See you all next time.